That looks good.
Okay, thanks. For those of you who I haven't met, my name is Anand. I'm the renal pathology fellow, and I'm going to show this case which I which we received from Alaska. We don't have the nephrologist here today, so I'm just going to very briefly summarize the clinical history. This was a 65-year-old man with a history of hypertension and diabetes who received a transplant due to end-stage kidney disease from presumably diabetic nephropathy. The transplant was done in June of this year. The post-transplant course had a few complications, including a large seroma at the incision site, worsening hypertension with a peak of 211 over 93, and BK viremia with a viral load getting up to 218,000. And so he had an acute kidney injury about a month out of transplant and was sitting around 2 to 2.5 for his serum creatinine, prompting a kidney biopsy. I'll just briefly go over his immunosuppression history. So after the transplant, he was induced with 3 doses of ATG, was on mycophenolate, tacrolimus, and hydrocortisone. And then with the BK viremia, the mycophenolate was stopped, and then they started leflunomide. Okay, so before I show the slides, I'll just briefly ask you to think about what would be in your differential diagnosis. This is not a trick question. And I'll pause for a moment and while I just get the slides pulled up. Let me go back. The BK virus load was, I think, 200. Oops, sorry.
Yeah, I think it was 212,
Yeah.
218, yeah.
Okay, so the main clinical concerns, as you would guess, would be for BK nephropathy, with rejection being the main differential. And then there was also some concern about those high blood pressures, whether there might be injury related to the hypertension. Okay, so we got looking at this biopsy at low power, we have a single core with a pretty good sample of both cortex, which is on the left side of this biopsy with the glomeruli present, and then we have medulla on the right. And the low power impression, starting with the cortex, it looks overall fairly well preserved, with these tubules being, for the most part, back to back. And I'll start by showing over here. Sorry, I forgot to mention at low power. So most of this looks fairly well preserved. And then there's this area next to the medulla, which where the tubules are more spaced apart and it looks kind of bluish gray. And so there's something infiltrating in the interstitium focally on that end. But before I get there, I'm just going to start with the kind of more superficial cortex, and we'll briefly look at the glomeruli before we get to the tubules and interstitium. So here are a few examples of glomeruli which are patent and look fairly normal. We have open capillary loops, so no significant inflammation in these glomeruli. There's some very focal atrophic tubules with their thickened basement membranes and a little bit of fibrosis in this area, but this is a very small fraction of the overall sampled cortex. I'll show you one other glomerulus here, which has most of it looks patent. There are some open capillary loops here, but there are some capillary loops that are obliterated and filled with dark, like black material, which would be collagen. So this segment is scarred, and it doesn't show up very well in the scan slide, but in these capillary loops, there are also foam cells. You might be able to see this isn't just open white space. There's some kind of bubbly appearance. And so these are foam cells that are filling in the capillary loops. And so this glomerulus is segmentally sclerosed. And this is the only glomerulus that had segmental sclerosis. But proteinuria wasn't a significant concern for this patient, so not the primary area of interest for this particular biopsy. Okay, so now we're deeper in the cortex and right next to the medulla, and we see that area that I pointed out at low power where the tubules are spaced apart. And now we can see that what what's spacing them apart is this dense infiltrate of cells, which are mononuclear, so lymphocytes and plasma cells. And in a few minutes, we'll get a better look at what these inflammatory cells look like on the H&E stain. And there's also, in addition to the inflammation in the interstitium, there's a little bit of tubulitis. And so, for example, in this tubule, the normal tubular epithelial cells have relatively pale nuclei, and we have some infiltration by these dark nuclei, which are lymphocytes. So we have a patchy tubulointerstitial inflammation, which is, at least in the cortex, is primarily in the deep juxtamedullary region. And then we'll go down to the medulla. And in the more superficial medulla, it doesn't look that abnormal, but as we get deeper into the biopsy, we see more and more inflammatory cells that are spacing apart these tubules again. And again, we'll get a better look at these inflammatory cells on the H&E stain. So I will go there now. Okay, so we're now on the H&E stain, which gives us a clearer view of the morphology of the cells. And I started by showing the area in the deep cortex that was inflamed, and we see again that these are mononuclear inflammatory cells. The detail doesn't show up quite as well in the scan slide, but we see that these are all mononuclear, so lymphocytes and plasma cells, and we'll look down in the medulla as well. And I think here we have a few clearer examples of plasma cells. So the one of the main features that help us identify a plasma cell is what we call a perinuclear half. And so here, here's a good example. Here's the nucleus, and right next to the nucleus, you have kind of a C-shaped area that's pale pink. So and here's another example here. So this is the Golgi and these plasma cells, which are spewing out antibodies. And then we'll look at now at the epithelial cells in these tubules. And the first thing we see is that these nuclei are really large and irregular shaped compared to what we normally see in the tubule. And in the nuclei, in many of them, we can see this cleared out region in a portion of the nucleus. And then we see a few examples like here, where there's a large irregular shaped nucleus in the cell that's kind of degenerating. So it looks really fuzzy and it's losing some of its detail as it's dying. And this degenerating cell is getting sloughed into the lumen of the tubule. All right, so I just have a few static images to summarize the light microscopy findings. We had an infiltrate of lymphocytes and prominent plasma cells that was patchy and predominantly in the deep cortex and medulla. We have reactive changes in these tubular nuclei with intranuclear inclusions. We had some of these cells with the atypia are getting sloughed off into the lumens. And then we had the incidental finding of a segmentally sclerosed glomerulus. And so again, here are some open capillary loops. Here's a foam cell filling in a capillary loop. And here's an area where we don't see clear capillary loops at all. By immunofluorescence, we had a few findings. There's some modest staining for IgG in these mesangial regions predominantly. There is also modest C3 deposition. And then looking at the kappa and lambda light chains, we saw a bias. And so there's much brighter staining for the lambda on the right compared to the kappa on the left. And this is true both in these intratubular casts as well as the background staining in the interstitium. Okay, and so because of the clinical suspicion for BK nephropathy, plus the findings which I was kind of alluding to that increase our suspicion, and I'll talk more about that later, we did this immunohistochemical stain for SV40, which is an antigen that we'd find in polyomaviruses such as BK virus. And so in immunohistochemical stains, the blue is the counter stain for nuclei, and a brown signifies a positive stain. And we see quite a lot of positive staining. The positive staining is in the nuclei, and we see the most positivity in the deep medulla and this inflamed area in the juxtamedullary portion of the cortex, with pretty minimal staining out here in the more normal appearing superficial cortex. Okay. It's a bioelectron microscopy. Here's an example of one of those degenerating epithelial cells that's getting pushed out into the lumen. Here is its nucleus, and then within the nucleus, we see this inclusion, which at this lower power just looks like a kind of a blob of more electron-dense material. But if we look more closely at high power, we see this really remarkable kind of almost crystal-like arrangement of these viral particles. We don't quite have the detail to tell the shape of these, but you can tell that they're kind of all uniform and tightly packed together. All right, so putting this all together, what we have is polyomavirus nephropathy, which was very strongly hinted at based on the pattern of inflammation, where we had plasma cell-rich inflammation that was primarily coming from the medulla, and plus the viral cytopathic effect that we saw in the H&E stain. And this was confirmed by the SV40 immunohistochemical stain. And I'll note that we're calling it polyomavirus and not BK virus, just because the SV40 stain is it's specific for polyomavirus, but does not distinguish BK virus from other polyomaviruses. And then we had a few other incidental findings that are probably not contributing to the acute kidney injury. And so there was focal and segmental glomerulosclerosis. There was some modest IgG and C3 deposition that we saw by immunofluorescence, but didn't see significant immune complexes by electron microscopy. And then there was a lambda light chain bias, which we think is just related to a strong inflammatory response to the BK virus. Okay, so I'm going to just give a few take-home points for the diagnosis of BK virus. I'll first note that BK virus is a fairly ubiquitous infection that tends to stay dormant in the bladder, in the lower urinary tract until there's immunosuppression that would lead to reactivation. And so this explains why you can often see viruria, which isn't necessarily specific for a clinically important infection. Whereas if the virus ascends up to the kidney and causes nephropathy, that can cause viremia, which is significantly more specific, especially if you have a high viral load, such as this patient getting towards about 200,000. And this also explains, since it's an ascending urinary tract infection, it explains why we saw the most intense inflammation and the staining in the medulla and the deep cortex, since it's coming down from the lower urinary tract. The BK virus falls under the polyomavirus family of viruses. These are double-stranded DNA viruses, and I won't go through their whole viral life cycle, but I will note that the viral particles are assembled within the nucleus, and so this is why we see the viral cytopathic effect and those intranuclear inclusions on light microscopy, and also explains why we saw those tightly packed viral particles within the nucleus by electron microscopy. Okay, and the final point I'll make is that although we're able to make a diagnosis of polyomavirus nephropathy, we're not able to rule out a combined component of rejection as well. So I'm showing side-by-side image from this case on the left and an example of T-cell mediated rejection, which also has very overlapping features with interstitial inflammation and tubulitis. There were a few features that I described, such as having the richer inflammation deeper into the tissue, and um, the having rich plasma cells that help us to suspect polyomavirus, but these are features that you can still see in rejection. And we'd also note that with BK virus nephropathy, you're getting damage to the kidney, which can prime the immune system. And so this might actually set up the kidney to have rejection. And so we just have to have careful phrasing that although we diagnose the polyomavirus nephropathy, we can't rule out a combined rejection. All right, so that's all I have for this case. I'm just checking the questions in the chat. There's the question about if BK viruria, how often the SV40 stain is negative. I don't have numbers, but I'd say most of the time we very rarely see BK virus here. This is my first case since starting fellowship. Whereas I think viruria is quite common. But we do have a fairly low threshold to get that stain to rule it out because it can be a patchy process. So even if by light microscopy we don't see all that much to suspect BK virus, we'll still get the stain to help rule it out.
Thank you, Anand. That was a wonderful case. Again, I think another key teaching point here is the viremia, right? So it's much more specific, and especially super high levels like this in the 200,000 range has a very high predictive value for also having kidney involvement, kidney damage by polyomavirus nephropathy, as we saw in this case. So this is really, one of those textbook examples here for this particular case and the presentation of this entity.
All right, I think we'll
Any other questions?
Was there a reason why medulla was? I mean, you'd expect that there's low flow to medulla compared to cortex, and most of the stuff was in medulla compared to cortex.
Yeah, so I think that's because it's ascending up from the bladder, and so just where the virus is, rather than coming through the bloodstream, I think the virus is coming up the urinary tract. Is that?
But then you would expect viremia first before nephropathy, right? So, as opposed to biuria in more than 1 million copies, and then viremia, and then nephropathy.
Sorry, I don't. Can you? I didn't understand what you meant with that.
My understanding is that you get nephropathy, and before nephropathy, you get viremia first. I mean, first is viuria, then viremia, and then nephropathy. So it's in the blood before it gets into the kidney.
I don't think that we can say that. So the fact is that, I mean, when we do the biopsy, that's a very small sample. So basically, that's only about the probability of seeing the BK virus or SV40 positivity in the kidney increases as you have viremia, and so that's the correlation. But I don't think that we can say that viremia occurs first and then the virus comes to the kidney afterward. Rather, as you saw in this biopsy, that there were more basically SV40 positivity in the deep cortex, and if we have a good sample of medulla, even you will have more chance of seeing positivity there. That is more supportive that indeed we have the infection distributing in the kidney in an ascending way.
Well, I would just add that the viremia is also the organ and where the infection is. So in the bladder, you have transitional epithelium, multiple layers. There, the virus infects that epithelium. Most of it's getting shed into the urine, and it's not really gaining access to the blood. Whereas in the kidney, you have that single layer of epithelium, you get inflammation. And so it's just a matter of the virus having more ready access to blood when it makes it up to the kidney. And that's why the viremia, in my opinion, is a more specific marker for a nephropathy versus just the bladder infection.
Yeah, and the exact timing is kind of hard to pinpoint, right? When we have a single biopsy sample, and often in these cases, it's done after there's already viremia at a pretty high level. So I think that's the challenge, and even the life cycle of the polyomaviruses is interesting, right? In terms of how it's transmitted, and maybe it's a respiratory transmission, but then it sets up shop as a latent infection in the lower urinary tract. So I think there are some gaps in our understanding of the transmission and its circulation in the body. All right, thank you for the discussion. Maybe we should move on to the next case for time. Thank you, Anand. That was a really great case. Thank you.
Okay, good morning, everyone. Sorry for the technical difficulty. I had to move to my laptop to be able to talk to you guys. And thank you very much, Anand. That was fantastic, beautiful case. It was quite some time that I had not seen such a classic polymovirus nephropathy. Okay, so with that, let me share my screen and go to this. Okay, so are you seeing the screen well?
Looks good.
Okay, perfect. Okay, so 44-year-old diabetic man with anasarca, and Dr. Malik will be discussing the clinical history.
Thank you, Azad. Good morning, everyone. So, are you going to advance this, Azad, or?
Absolutely.
Okay. So this was a 44-year-old man who came to our attention for the first time after he was hospitalized. So he had a history of type 1 diabetes. And as you can see, had all kinds of end organ problems, neuropathy, vasculopathy, had transmitted household foot amputations, also retinopathy and gastroparesis. So together with that, he had hypertension as well. And what he described as a remote history of polysubstance abuse and was now on the methadone program. The reason, I think part of the reason that he came here, and I'll talk about in just a minute, he had been having this severe anemia for a long time, for which he was getting evaluations at Swedish. So it was almost to the point of getting transfusions as well. So he, as you can, his previous outside hospital medications were pretty simple: amlodipine for blood pressure, insulin for diabetes control, and Lasix for his volume control. Next, Prasad. So he was admitted, sorry, go back for, yes. So he was admitted late July to UW, Montlake, and so with volume overload and anasarca, uncontrolled hypertension into the 190s over 90s. And again, as I alluded to, he'd been having this anemia for many months, getting periodic transfusions at Swedish. But the thing that we noted, and the reason we were called, was that he was having this progressively worsening renal failure of a pretty fast rate. He was almost pretty normal in October of last year, and then he has rapidly progressed to about 3.7 on presentation within a matter of about 8 to 9 months. Next, Prasad. So for hypertension, he was started on carvedilol with amlodipine. For control, he had a echo, which was notable for markedly elevated right-sided pressures with normal left-sided ejection fraction. So his pulmonary artery systolic pressures were pretty high with increased CVP. So there was some concern whether he had underlying pulmonary hypertension as well or not. He showed signs of congestive hepatopathy, a lot of anasarca. So we had to use a small albumin infusion associated assisted IV diuresis. And then he was switched to oral torsemide for further control. And there were a few other small changes in his diuretic regimen along the way. His hemoglobin A1C, when at least he came, was stable, was 7.1%, though it had been a bit worse in the past. So as I mentioned about the anemia, he was around 7.5 on his hemoglobin. Other white counts and platelets were pretty normal. And his iron panel is listed there. It was probably showing some hyperferritinemia and low erythropoietin based on his anemia. B12 folate were normal. We did haptoglobins and peripheral smears, they were normal. So his nephrotic syndrome evaluation included pretty significant proteinuria of 3+, which was later quantified as about 5.7 grams, of which the majority was albumin. And he was pretty hypoalbuminemic. And we did extensive secondary serologic work, and it was all negative. So I think, and while he wasn't hospitalized, so because of diuretics, because of trying to control his volume, his creatinine progressively continued to get worse. And when it went up to around about mid-4s, the decision was made to see if we can find what is causing this very rapid drop in renal function. So he underwent a biopsy. Okay, so before looking at the biopsy, type 1 diabetic patients, all sorts of different complications, anasarca nephrotic syndrome, a little bit of blood in the urine, history of polysubstance abuse, amputation. What are your differentials? Just shout it out or type in the chat. So membranous AA amyloid, DKD, okay, all are good. DKD and amyloid, yes, with that history, that makes sense. Cardiorenal, a component of that is reasonable. DKD and FSGS, Ian, yes, of course. DKD and cardiorenal. Okay. Yeah, I can see good points in picking those differentials. So let's take a look. There's some delay. All right, okay. So these are various pictures, low magnifications of the biopsy that we received. It's a good sample. And this is Jones methylamine silver that you are familiar with by now. And we have 30 to 45 glomeruli per level section. And as you can see, there is a lot of black and gray stuff. So there is just at this low magnification, you can tell that there is a lot of chronic injury. And that was also reflected in the glomeruli. So about a third to half of the glomeruli were globally sclerosed. And also, there was at least moderate interstitial fibrosis and tubular atrophy. So these are the areas of the tubules that are more preserved. And these areas that are black and gray, they show significant scarring. And also, many of these glomeruli, I mean, some of them, you can see that, okay, it kind of looks patent. Many of them, they were just like black balls. So they were globally sclerosed. So now let's take a closer look. So I saw that, with that history, I mean, obviously you were all thinking that there is diabetic kidney disease, and here you go. So what we have is nodular glomerulosclerosis, very typical, diffusely in all of the glomeruli. So you see, as you can see, there is very prominent expansion in the mesangial regions. That this PAS stain is very nice to pick that up. And then we have these nodular lesions, and these nodules are primarily composed of matrix. As you can see, we don't see any nuclei here. And when you look at these ones in the middle, we don't see nuclei. Rather, the nuclei are like arrayed in the periphery. And in some areas, however, it's becoming a little bit more cellular. But the dominant picture are presence of these nodules that, they have a lot of matrix in the middle. And in the periphery, maybe they have open capillary loops, and also they have nuclei arrayed like that. So kind of like looking like sunflowers, right? And in the outside, when we look, also there is chronic injury, of course, tubular atrophy and interstitial fibrosis, and also some chronic inflammation. I mean, this other guy that you see, there is also some ischemic changes. There's some Bowman's capsule thickening, as well as there's a collection of these epithelial cells.
one may ask that, are these crescents or not? I mean, you count, so for the definition of crescents, we say that we want to see 3 layers of epithelial cells or whatever, and maybe these approaches that, but we did not see any fibrin or necrosis or obvious glomerular basal membrane break. This is an H&E stain, and by H&E stain, also kind of similar changes, right? I mean, we have these nodules. Some areas they're more cellular, some areas are more typical of what we call as Kimmel-Wilson nodules. And arterioles, you know, we with H&E we can't assess very well, but this doesn't look certainly like normal. And we have chronic injury in the background. This glomerulus also has some synechia to the Bowman's capsule. So we have typical changes that we attribute to diabetic kidney disease, of course. And that was throughout the entire biopsy. This is, again, another arteriole, and with some hyalinosis and also some endothelial swelling, but no like obvious thrombotic microangiopathy, because endothelial swelling is one of the things that it brings you know, the concern for thrombotic microangiopathy. Even in the globally sclerosed glomeruli, we had the same pattern of nodular glomerulosclerosis. So even if I had one of these globally sclerosed glomeruli, I could guess that, okay, PKD was the main thing. Now, okay, now we get to this part, and that is many of these glomeruli that were not globally sclerosed. Many of them, they had what we call segmental sclerosis. So segmental sclerosis is like obliteration of capillary loops, right? And this is a foam cell here, or maybe there is some hyaline like you see here. And in most instances, we also have some adhesion to Bowman's capsule. But also they had this interesting feature that if you look where we have the adhesion to Bowman's capsule, it looks like that there is a collection of extracellular matrix in these glomeruli, and it looks like the Bowman's capsule basal membrane, maybe it is even duplicated. We have this prominent thing, and in many of these, I mean, in this one here is got to be close to the vascular pole. We have the arteriole, so probably this is close to the glomerular junction, as well as here you see that it's extending into the glomerular junction. And in fact, in some of, when we had the perfect cut, we were seeing this more prominently. So as you can see, there is a lot of things. And in this particular picture that I'm showing, as you can see, there is not a lot of dark stuff. So the dark stuff, as you remember, that means extracellular matrix, like you see a lot in the mesangium. So it looks like there is some fresh things in here as well, maybe some plasma protein-like material. Some foam cells were there, and also mixed with some extracellular matrix. And here you can see that this process, which is quite prominent in this glomerulus, extends well into the glomerular junction, kind of like suffocating the glomerulus at the glomerular junction. It's completely obliterated. And this is a profile of a glomerulus through the Bowman's capsule. You don't see the glomerular top. But as you can see, that phenomenon is very prominent. It is extending well into the proximal tubule. It looks like that it is even dissecting the tubular epithelial cells, pushing them kind of here to the side with foam cells and kind of protein material. And you kind of suspect that even this part that we're seeing is actually indeed connected on another level to this portion of the proximal tubule. So this is the proximal tubule that we're looking at, right? A continuation of the same material that we call parafiltration into the proximal tubule. Again, very prominent, really prominent. And look at that in these two examples also, we have some extracellular matrix, but it is not all solid. So it looks like really the term parafiltration, that means that we have some filtration of fluid and plasma protein material going inside. So changes very much classical for diabetic nephropathy, and also we have segmental sclerosis, and the segmental sclerosis is associated with this very, very prominent, basically like dissection of the Bowman's capsule basal membrane, parafiltration and extension into the proximal tubule. By immunofluorescence staining, also pretty much not basically any significant staining inside the glomerular tuft. Here is the glomerular tuft. But for the immunoglobulins, and most prominently for IgM, we had exactly the same mirror picture of what we saw by light microscopy. As you can see, very beautiful staining for IgM that is extending. And again, most likely this is the continuation of the proximal tuber. So this is glomerulotubular junction, glomerular tuft, parafiltration into the Bowman's space, extending into the proximal tubule and going down. Okay, so of course, questioning that, okay, we have diabetic nephropathy for sure, and it's advanced diabetic kidney disease. Is there, as Ian was suspecting, is there FSGS superimposed, or is this the correct way to put it? Because is FSGS a lesion or it's a disease? So now let's look at the electron microscopy, because sometimes we hope that electron microscopy may give us that answer, which may not be the case in many instances for answering this particular question. So by electron microscopy, what we see is that these are the capillary loops. You see some red blood cells in the capillary loops, very prominent expansion of the mesangial regions in a nodular pattern. So the same Kimmel-Wilson lesions that we saw by light microscopy can be seen by electron microscopy. Glomerular basal membranes are thickened, are very prominently thickened. We do not see any immune type deposits. Here is the lumen, and a red blood cell is there. And so here is the mesangial region. And the mesangial region is expanded. We see that there is a lot of mesangial matrix, which is characteristic of diabetic nephropathy. And just in the neighborhood, here is another capillary loop. But look at this entire region. The mesangial matrix is loose, is kind of electron lucent. And the mesangial cells are kind of like expanded, and the mesangial regions are frayed. This is what we call as mesangial lysis, and that's the basis of nodular glomerulosclerosis. So we had mesangial lysis, and in terms of food process effacement, that's one of the things that in idiopathic FSGS is typically associated with extensive effacement of food processes. So when we look, we compare this is a high MAC, this is a low MAC, and we see that there are some areas with more preserved food processes, and there are some areas that we have a lot of food process effacement. So the food process effacement was segmental, something that does not quite support an idiopathic or primary form of FSGS. And we saw the same thing also by electron microscopy. That parafiltration that we saw, very nice, basically, expansion of the Bowman's capsule basal membrane. It looks like basically more solidified in this particular picture. And when we look at the tubules, also thickening of the tubular basal membranes, interstitial fibrosis, and the same picture that we saw by immunofluorescence and light microscopy. So kind of like detachment of the tubular epithelial cells from the original basal membrane, and a collection of this loose material, even with some cells that maybe some of them are inflammatory cells. So yes, diabetic kidney disease, advanced diabetic nephropathy, and also we had other things, and we had focal global and focal segmental glomerulosclerosis. So 23% of the glomeruli were segmentally sclerosed. Many of them, they were at the glomerulotubular junction. So does that mean that the patient has FSGS tip lesions superimposed on diabetic kidney disease, and that's the cause of nephrotic syndrome? I don't necessarily think so. So basically on serial sections, as you know, as Remuzzi also shown that, but when you do serial sections for picking FSGS lesion, again, I stress on lesion, an FSGS lesion, if you just rely on single sections, you only pick up about 25% of instances of FSGS. So if we do a study of serial sections in type 1 diabetes, especially, I mean, in this case, and we look at the location of the segmental sclerosis or adhesion to the Bowman's capsule, indeed, about 60% of them are at the glomerulotubular junction, as you can see. So it's a very common thing. and it is associated with heavy proteinuria and nephrotic range proteinuria. So often when we see this, we favor that. Actually, I mean, this is part of the advanced diabetic kidney disease. It's a totally different story if it abruptly starts, and if in the biopsy, where it's in the short, basically duration after the onset of diabetes here, type 1, so we know when the onset was, and also if on the biopsy we do not see prominent diabetic nephropathy. So the interpretation would be totally different if we are in any of those situations. Then we think of a superimposed FSGS, but not in this case. Okay, questions, comments, or any follow-up if Dr. Malik has?
Well, I've seen him once since that time, and of course, as things stand, he's progressing toward end stage, so we are getting him an AV access as we speak.
Compared to tip lesion FSGS, where IgM is thought to be either passive trapping versus playing a role in causing C5b9 expression and progression of FSGS, what's the role of IgM trapping in these cases? Is it just passive, or do they have active?
The parafiltration is not limited to diabetic kidney disease with FSGS lesions. So, as Kritz has shown beautifully, I mean, you can see parafiltration in any form of FSGS, including, the primary FSGS as well. And you can see that. And the IgM, prominence of the IgM, it's not only IgM either, but IgM is more prominent in these areas that, we call like, you're saying trapping, that means that there is simply some fluid. However, in FSGS lesions, we also have IgM in the mesangial regions sometimes. And, commonly we have a little bit of IgM, we may have a little bit of complement, C1q or C3, as you mentioned, and it has been shown that it may have some pathologic role. In this condition, we do not exactly know, but it certainly it is commonly seen alongside with the C3 and C1q, similarly in diabetic kidney disease, which is associated with this lesion. So is it very different, or is it just, as you're saying, that trapping, or is it making it worse? It's not quite now.
So if I could add, I can't resist. So I'll share my opinion. People use the word trapping a lot, but really, IgM is the class of antibodies that has all of the natural antibodies. So anytime you get injury and exposure of like matrix and other types of antigens, these natural antibodies are going to bind and stick there. And so we see IgM and complement in areas where we do see this sort of non-specific injury, and it's a very, very common finding. And so the complement that we see there is likely a manifestation of complement activation due to the binding of natural IgM antibodies. This is in many instances is probably just a normal physiological process to help us repair injury. But if the injury is pathologic and ongoing, then it's augmented, and we see a lot more of it. So that whether it's contributing to the disease or just a marker of disease is, I think, one of those arguments that we can have over a few years.
So, Bazad, if I may, I'd like to add some nuances and maybe a little bit different interpretation to some of the structural things you showed us. The first would be, is I'm not sure that it's splitting of Bowman's capsule. Stuart Shanklin here has really emphasized and taught us much about parietal epithelial cells and an underlying parietal epithelial cell basement membrane. And what I think happens is there is an infiltrate that ruptures through the parietal epithelial cells and parietal epithelial cell basement membrane and dissects and creates what is a potential space into a very significant space between the parietal epithelium and Bowman's capsule that gets filled by this filtrate. And that too is what the term where Kritz used in his experimental models, the term misdirected filtration.
Yeah,
the second thing is about what we're calling it. Can I go on just one other thing?
Yeah, go ahead.
The second thing is, just with the pictures even you have up now, what we're calling a tip lesion, I think, is very different. You showed us elegantly the mesangial did not emphasize so much in this case, but that frequent fraying of the mesangial capillary interface, the capillary loop basement membranes, where they're reflected over the mesangium, get untethered, and we form dilated capillaries. They form microaneurysms, and these aneurysms can rupture. And I think you're showing in these attachments examples where microaneurysms have ruptured into that parietal epithelium and parietal epithelial space, and the organization of the sequela of the filtrate and the rupture is what we're calling, could be called segmental sclerosis or tip lesions. And I think they do preferentially happen at the tubular pole of the glomerulus for hemodynamic reasons that makes the microaneurysms in those sites more susceptible to rupture.
Yeah, there are different reasons. That's the way that I see it. We have shown that basically in earlier instances of tip lesion that happens in diabetic nephropathy, basically you see exactly similar tip lesion with foam cells and with initially without this very prominent parafiltration that we're seeing here. So looks, and I think that that's one of the pictures that we also included, you and I, in Heptinstall, that you can look at. So we have the foam cells exactly the way that you see it in FSGS tip lesion over there, and then we have the parafiltration. But the rupture of the capillary basal membranes, certainly that happens. Why it happens more frequently at the glomerular junction, we do not exactly know. One of the hypotheses is the presence of accentuated shear stress on the podocytes at the glomerular junction. And the other hypothesis is that basically the most proximal portion of the proximal tubule is more affected and more exposed to higher levels of protein. There are different hypotheses, and the rupture of the basal membranes also happens, and probably there is more than one path to get into these lesions. So whether how different this is from what we see in tip lesion FSGS, I can say that there are more than one pathway probably in the FSGS, but we can definitely see tip lesion pretty much indistinguishable from what you see in typical primary FSGS in diabetic kidney disease as well, in terms of morphology. And for the dissection, I believe that basically what happens is also lifting up of the parietal epithelial cells initially and new basement membrane formation. And the progression of these is looking like that there is dissection, similar to what I showed in the what happens in the tubules. So in the tubules, the same thing occurs. So it looks like there is this enlargement of tubular epithelial cells, a little bit of separation from the initial basement membrane, and then we have new basement membrane formation. So that's basically what I meant by dissection. So I think that what we are seeing is basically the same.
Great. Well, I would say we should move to the final case.
Yes, yeah, please, yeah.
Thanks. Okay, I will share my screen. Okay, so hopefully everyone can see this. It's the third case. Oh gosh. Unfortunately, how do I move this?
You should be able to just use the left and right arrows.
There we go. Okay,
Yep.
It's working. So here the clinical history is a 67-year-old female with recurring acute kidney injury. She has a history of metastatic high-grade endometrial carcinoma, seizures, mild hypertension, The carcinoma was diagnosed about a year ago, treated with carboplatin and pembro, and then for 4 to 5 months, followed by a higher dose of pembro and lenvatinib for a few months, and that was stopped about 5 months ago. Recently, she was started on a trial with a new CHEK1 inhibitor, acroviron 368, also known as prexasertib, and then switched. In addition to that, she was switched from her Keppra as an anti-seizure medication to Lamictal. So about 2.5 months prior to the biopsy, the patient had tubular proteinuria and pyuria in the setting of a diffuse rash, vomiting, neutropenic fever, and sepsis. That was at the time, it was shortly after she started the Lamictal and prexasertib, and she had received 2 doses of prexasertib at that time. A drug reaction was clinically suspected, as well as concern for Stevens-Johnson syndrome. Her serum creatinine peaked at 1.9, and there was clinically suspected acute interstitial nephritis. She improved with conservative measures, and they believe steroids, but that's not clear from the records that they received. About a month and a half later, the patient was admitted with COVID-19 infection and exacerbated kidney injury. So at that time, the kidney injury was attributed to COVID-19, and she was treated with remdesivir and a short course of dexamethasone. Creatinine peaked at 2.7 and then improved to 1.1. Then about 3 weeks prior to this biopsy, the serum creatinine abruptly rose to 2.67. Urinalysis showed pyuria and minor proteinuria. And then 2 weeks later, the serum creatinine had improved to 2.1. The renal biopsy was done at an outside hospital. It was inadequate. There was only muscle and some fibrous connective tissue. Other labs of note were there was a marginally low C3 and a low ANA titer. Here's the course of the serum creatinine. So started on Lamictal and prexasertib. Creatinine increased. Then she had the rash. Thought maybe Stevens-Johnson syndrome, treated conservatively, recovered, and then COVID-19 infection, bumped up again, treated with remdesivir and dexamethasone, dropped back down, and then popped back up again, and then was treated. Biopsy was a bust, and then we're at this point in time where they're actually going to decide to do another biopsy. So the assessment was there was a high clinical suspicion for a recurring interstitial nephritis that was likely initially drug-induced with a history of DRESS and systemic inflammatory syndrome. So initially improved with conservative measures, maybe steroids too, worsened after COVID-19, then improved with treatment that included a short course of dexamethasone. And their plan at that time was to repeat labs after the course of steroids, to decrease the potassium, continue bicarbonate, and then consider another diagnostic biopsy. So at this point, I mean, it's sort of this classic case of recurring acute kidney injury. So I'm sure everyone, is familiar with that. But are there any questions or any considerations for the diagnosis or whether or not you would perform a biopsy? Okay, I'm not hearing anything, not seeing anything in the chat. I'm guessing everyone is confused and might want to look at a biopsy. Okay, so here's the biopsy. We have a fairly decent core present. This is the Jones-Silver stain, and I'll zoom in here. We'll go up here towards the cortex, and just taking a look at here, we can see that right adjacent to the capsule, there's some subcapsular fibrosis, tubular atrophy, also some interstitial inflammation. This is fairly nonspecific, very common to see. There's a sclerotic glomerulus. There's some other glomeruli that look ischemic and some that look not too bad, just looking at higher power. There is some bad arteriosclerosis present and arteriolar hyalinosis. Glomeruli, as we get farther away from the capsule, look pretty decent. But looking at the tubules, we're seeing evidence of tubular injury. So we're seeing acute tubular injury. There's attenuated epithelium. We see sort of areas without any nuclei present, consistent with injury to the epithelium and then trying to regenerate after that injury process. There is a little bit of interstitial inflammation present here as well. We keep on coursing down through the renal cortex, and we're still in the renal cortex, and then, we have a little bit of a focus here of interstitial inflammation. So a little bit more expansion of the interstitium, maybe some edema. We have some tubulitis present, more notable in this tubule here. So there's a small focus of interstitial inflammation in the cortex, and then some more evidence of acute tubular injury, where we see these white spaces, the dilated lumina, attenuated epithelium. Pretty much that. So focal inflammation, some acute tubular injury within the medulla, and then we're going, or in the cortex, and now we're going down into the medulla. Now we start to see, a little bit more inflammation. So we're seeing some mostly mononuclear cells, maybe a neutrophil present, sort of increased in the medulla. And we keep on going. A little bit more. This is close to the vasa recta, these arterioles present within the medullary region of the kidney. And we keep on going down, and now we start to see quite a bit more inflammation. And it's really a peculiar pattern of inflammation. We see a fair number of neutrophils here present within the interstitium, and a lot of these inflammatory cells that are just sort of lining up against the tubules, the tubular basement membrane here. A little bit of tubulitis, and then if we go farther down, it says, oh wow, look at that. We have here all these neutrophils that are present within this tubule. And, when we see this, the first thing we think of is infection. Is this a pyelonephritis, especially in the medulla? That's not a bad place at all to see a tubule filled up with neutrophils. But we do have this interstitial inflammation too that's quite prominent and sort of rimming and, forming these rims around these tubules with tubulitis. So we do have really an active interstitial nephritis with that is mixed with notable numbers of neutrophils and focal intratubular neutrophil casts that are forming within this inflammation. So we're here at a tubular interstitial nephritis. I think I'll pass the H&E and we'll move right on to the IF. So the IF was quite a surprise. This is looking at IgG, and we can see that within the cortex, we can see some of these tubular basement membranes that are getting decorated with IgG, but there's some glomeruli in here and other tubules that are not. So we're seeing more focal staining of the tubular basement membranes within the cortex. We're getting the juxtamedullary cortex. We're seeing more staining, but then areas of tubules that are really devoid of staining altogether. And then in the medulla, where we saw the predominant inflammation, we're seeing lots of tubular basement membrane staining for IgG. When we look at a higher magnification picture, you can see nice granular tubular basement membrane staining, very strong staining for IgG. This is in the medulla. It's really involving the tubular basement membranes. Here's some of the peritubular capillaries adjacent to them. Then here's some of the cortex. The glomeruli are negative, and then some of these proximal tubules adjacent to this glomerulus are also showing really no significant staining or very little. They stain for both kappa and lambda, so we're looking at a polyclonal process. And then looking at the electron microscopy, we see really normal appearing glomeruli, so really good preservation of podocyte processes, normal architecture of the glomerular basement membranes, mesangium that looks relatively nondescript. But then in the tubular parenchyma, we see a proximal tubule here with a nice brush border and a fairly normal appearing basement membrane. And then over here, we see more of a distal tubule with the stubby microvilli and a very thickened basement membrane that we'll look at higher power. And we see that this basement membrane is thickened because it has numerous electron-dense deposits that are filling and expanding the basement membrane. And then here's a higher magnification. So this correlates with the IgG that we saw, where we're seeing nice immune deposits present within the tubular basement membranes. So diagnosis, immune complex mediated tubular interstitial nephritis, acute tubular injury, and then some, again, some chronic injury as well. And then the comment was, just very succinctly put that it's, we felt that this is probably related to a drug reaction. So what about immune complex mediated tubular interstitial nephritis? This is a rare diagnosis. I mean, I think I've only seen this a handful of times in my career. It's reported to be rare manifestations of lupus or Sjogren's syndrome. I don't know if I have actually seen a case like this. There's been some cases of idiopathic hypocomplementemic tubular interstitial nephritis. Older reports of certain drug exposures, including methicillin and penicillin, can cause this type of phenomenon. That's thought to be sort of a hapten-mediated phenomena where the drug can bind to some tubular basement membrane proteins and then creates a neoantigen that leads to the immune complex mediated tubular interstitial nephritis. And then we did have a couple of patients that had rheumatic heart disease and developed AKI post-valve treatment that had this tubular interstitial nephritis with giant cells. And so we saw nice tubular basement membrane deposits, but also more of a macrophage-rich reaction. Instead of this one as a neutrophil-rich reaction to that thing. But importantly, this is really, really rare. So what about potential culprits in this case? So the lamatogene, is one, and then the prexasertib. Well, Lamictal is well known to cause acute tubular injury and acute interstitial nephritis. There's also several reports of it with TINU, so the tubular interstitial nephritis and uveitis syndrome. Typically, the reports describe a granulomatous interstitial nephritis and no tubular basement membrane immune deposits reported. So, even though there's the AIN link here, the pattern of inflammation that we're seeing in this patient doesn't really fit what's been reported in the past with this drug. What about prexasertib? Well, it's a new drug and there's not a lot out there. So there's no reports of AKI or AKN that's been attributed to prexasertib. There was, for instance, one clinical trial where there was 1 out of 60 patients that had a grade 4 AKI, but for some reason the people didn't attribute it to the actual drug itself. So I think that's a big unknown or a big mystery at this point. So does this finding explain this patient's prolonged relapsing course? Is tubular basement membrane immune deposits provide sort of a cause or an etiology for this relapsing course? Well, it's possible that the immune deposits formed during that initial presentation where they had the rash, the vomiting, nausea, and then that might have been the initial cause, and maybe that was resolved. Maybe the patient did get a little bit of steroids to help resolve that inflammatory process. Possibly the COVID-19 infection exacerbated an immune response to those existing immune deposits. So it was attributed to COVID-19, but maybe that also sort of souped up the immune system and actually exacerbated an immune response to a planted immune complex mediated process. So there's some precedent for reports of flares of kidney disease after SARS-CoV-2 infection. Notably, IgA nephropathy is one of those where it seems like there's a little bit of an augmented disease once people are infected, as well as when people get vaccinated. The other thing of interest is that treatment with steroids alleviated the symptoms and led to improved serum creatinine. So, there's some hint that maybe some steroid treatment earlier on, may have led to sort of a partial recovery. But as you can see from the biopsy, there's still immune deposits there. So when they did they form, 2.5 months ago? And has that been the cause of this course of disease, or is this sort of a mixed bag? In the end, this piece of information and the fact that there's this immune complex, these immune complexes sitting in the tubular basement membrane, I think influenced the nephrologist to really try consider a longer-term steroid treatment to really try to keep the tubular interstitial nephritis in check and maybe give the body an opportunity to clear or resolve all those deposits. So that is all I have for this case, and I'm ready to open it up for any questions or comments if anyone has them.
And I would say that her previous treatment with immune checkpoint inhibitor might also have primed her for further immune insults down the road.
Yeah, that's a good point. And is that, Bilal, is that true with the timing, even though that it was several months back, would you still consider that likely based on what's been reported?
So yeah, I probably wouldn't attribute it to the pembrolizumab that she got, because that was like 5-ish months ago, according to the history. But we have seen it with people who are on PPIs and are put on immune checkpoint inhibitors. So they develop interstitial nephritis, which sometimes we blame it on the PPIs because the immune checkpoint inhibitors are now facilitating the immune response against them.
Okay, I think we're over time, and unless Ram, you wanted to say something.
Oh, no, I just wanted to say thanks, Kelly. That was really impressive. I just recall a case that I think I shared with you a few months ago, also probably a drug-related reaction with immune deposits that we were also considering for anti-brush border disease. So there was more of a proximal tubule kind of immune deposition process. So, but there was, again, I'd have to go back and see what drug was a potential offender there. So yeah, rare, but kind of an interesting presentation in the kidney.
Well, we'll close for time. Thank you to all the presenters, to the discussants, some really beautiful images and fascinating physiology. A reminder, and just to prime everyone, our next in-person session is our pre-ASN nephrology grand rounds in 2 weeks on the 27th, which will be again at South Lake Union. A really great lineup already. Nephrology, or University of Washington is going to be really well represented at ASN, and looking forward to seeing you all on the 27th. Everyone, have a good weekend. Bye.